I want to thank the organizers of this conference. I think it's almost an overload of information. It's been fantastic. And if you're like me, at this point, you're a little bit exhausted. So I admire all of you who are still here. I want to declare our conflicts. And I want to say that we wish to declare our focus on narcissism predates the display of such behaviors in the presidential race. Sarah anticipated, she and I are on the right framework, and Sarah even indicated that it's not alcoholism, and so it must be something else. So Alan Kandin has clearly articulated the steps in treatment development, and what we're talking to you about today, we're at the very preliminary beginnings of trying to articulate a coherent treatment of narcissistic personality disorder, if you will, or the domain of narcissism in all of its appearances. So we're really talking about trying to conceptualize the pathology and try to conceptualize the treatment and beginning to clinically assess it. So first of all, conceptualizing the pathology, how can we come up with a homogeneous group of narcissistic patients? I think, you know, you've heard so much about borderline personality disorder. We've spent 30 years trying to put together a coherent treatment for it. And of course, we end up with the dodo bird. You know, all treatments work, and all of them work to a certain extent. I think one of the problems is the heterogeneity. Linehan's borderlines in Seattle may be quite different than ours in New York, which are different than somebody else's. And I think the same problem is going to occur in narcissism. So for example, let's look at the neural level. We know from Fan and colleagues that there's an excessive focus on self in terms of brain functioning, in terms of the insula, for example. We know in terms of self-perception that these individuals have an exaggerated sense of self-esteem. But when you look closely, there's also some contradictions. Of course, the implicit and explicit self-esteem, there's often contradictions in that, hinting at what Elsa's talking about, so you can have a bravado of self-esteem, but very vulnerable underneath. And then, of course, at the phenotypic level, there's self-enhancement and dominant behavior in response to status and threat, and emotion dysregulation following social stressors. So these people react to rejection sensitivity, if you will, with a lot of anger and bravado. And this study, again, by Cascio, indicates some of the problems. So if you put these people in a cyberball situation like Eric was describing to you, they experience the rejection, but at a conscious level, they don't tell you they feel rejected. But at the brain level, you have indication that, in fact, they are experiencing the rejection. So that's the kind of contradiction that's going to come to, I'm going to skip this one for time's sake, and just go to the bottom line, which means that any treatment is going to have to deal with an exaggerated but very vulnerable sense of self-esteem, angry responses when threatened, possibly the person is unaware of their own response to social threats and rejections, and the patient does have the skill of cognitive empathy, as Elsa was saying, but not motivated to use it. So in other words, a skill-building approach probably wouldn't work because these people have the skill, the cognitive skill, but they are motivated not to use it. And of course, all of these things will be demonstrated in the here and now interaction with the therapist. So one thing that occurs to us is that it's fairly easy to get a narcissistic diagnosis by semi-structured interview. We can also measure this dimensionally, this whole narcissism phenomena, but how do we capture severity? And I think there's many approaches to this. I'll let you read it. one of the nicest ones is by Hopwood and colleagues, a nice paper where they take the total number of criteria on axis 2 versus the style, the different categories. The problem with that we have is that some of the criteria on axis 2 are much more powerful than others, so you're just giving equal weight to all of them. Our inclination is to use an object relations model, the one on the top, that we find, and we believe theoretically, but we also find it in our data, that you have narcissism bleeding into narcissism with a lot of anger and aggression, which then also can bleed into antisocial traits. So a focus on that dimension may give us the kind of severity marker that we will use as a covariate. So are we prepared to do some kind of trial? I'm not sure. You will hear today from my colleague Frank Yeomans and Diana Diamond what we've thought about in treatment foci. We have developed a semi-structured interview to capture narcissism, both the grandiosity and the vulnerability, in a larger context of identity, defenses, quality of object relations, aggression, and moral values. And that's probably where we'll go to get some of our markers of severity. We've examined attachment styles in borderlines with and without narcissism. And we've also gained experience using EMA with our borderline patients. We've also examined in great detail videotapes of sessions among our clinicians in their practices here in the city. I think Frank will go into this, but we see from our videotapes of sessions these patients present with, and let me back up. Why would a narcissist, think about one of our presidential candidates, why would a narcissist go for treatment at all? And seriously, that's a real problem. And of course, the most grandiose ones probably don't. It's the grandiose ones that have some sense of vulnerability and it's experiencing some pain in their lives. So we have a lot of these kinds of patients in our private practice here in the city. And of course, we have the problem with them relating to the therapist by devaluing the therapist, devaluing the therapy despite their current distress. As I said, we've developed this STIPO-R, this semi-structure interview, based on Kernberg's theory of object relations. And of course, we can put the narcissism and its vulnerabilities into a larger context. As I said, we've looked at a large cross-cultural group of borderlines with and without narcissism and see differences in the AAI. Clearly, the NBT, NPD, BPDs are almost twice as likely to be dismissing. It reminds me of the Cascio study in which you see at the conscious level, I'm not affected by things, and at the brain level, there is a real impact. And also, I'm going to put some emphasis on our use of EMA. You've heard a lot about that here, and I think that we will lean on that a great deal to understand the daily interactions of these narcissistic patients. We've used EMA, major authors Kevin Meehan and Nicole Kane. We've used it to study the impact of rejection sensitivity and borderline features on relationships in daily life. And we've shown the impact of effortful control on interpersonal behavior in daily life. So I think we're prepared to use this technique as a marker of change in a treatment. As Dr. Kernberg emphasized with you yesterday, the heart of the object relations theory, which is quite consistent with the CAPS model of Michel and Shota, is the centrality of representation of self, representation of other, and the related affect. The question is, how can you empirically, in a real-life situation, get access to that internal representation? By this time in the conference, you all know about EMA. So I would just show you that slide. You know that there's different ways of doing it. And what we're going to do is we're going to transform, or we are doing this now in a study of borderlines. So we've taken, we give the patient a smartphone with an app on it, and they simply indicate on the phone in this graph, and you'll see the object relations theory embedded in this. How do they experience themselves? How do they see the other person? So how do they see themselves in relation to the other person? And then the related affect. So what is the affect in that interchange? And so one very crucial kind of process outcome measure, as I see it in our study of narcissists, will be to see if there is a link between the transference interpretive process, hopefully related to modifications in the transference and the relationship between the patient and the therapist as the treatment goes on, and then in fact does that generalize to interpersonal relations in the person's daily life. My time is running short. So what I'm talking about, and we haven't done it yet, I would love to hear comments from you very smart people. We're thinking about doing a small N of 15 patients in our private practices with an NPD diagnosis, measuring severity, 2 sessions a week, and we would use waves of EMA as we progress through the treatment. And the primary outcome would be improvements in work and profession and friendships and intimacy. These people have tremendous problems in intimate relations. I talked about measuring severity, and these are the major questions of interest. Can we utilize a private practice setting to conduct a process psychotherapy study? How best measure the category, the dimension, and the severity? Will weekly review of sessions enhance and sharpen our treatment and our treatment manual, if you will? Which of these patients will drop out? And does the interpretation of transference lead to change in the transference and lead to changes in the real-life setting? And also using multiple measures, we'll try to see the rate of change. You will notice in this talk that I'm now ending a not-so-hidden criticism of the RCTs as they're done in psychotherapy research. I think psychotherapy research is coming to kind of a crisis, really, because all the RCTs with all the money and the larger the ends, we're always coming up with the dodo bird effect. That may be a true effect. It may be an artifact of our instruments not that good to pick up subtleties. So I would define an RCT in psychotherapy research at the moment as a horse race in which the focus is on the finish line, which way overshadows any growing understanding of how the horse actually runs. And we'll be trying to figure out how the horse actually runs as we get into the treatment of these narcissistic patients. Thank you for your attention at this very late time in the day. Question or comment or? Yes, Joe.
I wasn't sure what corresponds in your model to the borderline DBT emphasis on emotion regulation. Is there some way you can define what you're targeting to treat?
What would the target be in the treatment of the narcissist? The target, the specific target, would be their grandiose perception of self, their degradation of others, as that plays out in their grandiose sense of self in reference to the degradation of the therapist, and whether that becomes modified and whether you see that happening in their relationships in the everyday life. That make sense?
If only you could get them to agree.